to thank everybody who's here in person. We got a great turnout, particularly for a lovely end of summer day in Berlin. So thank you all for coming. We also want to acknowledge we've got a group of people that are watching us live streamed from our YouTube channel. So welcome to you also. So we are now hosting the 8th session of what we call our speaker series. And this is on harnessing contextual insights for better public health intelligence. My name is Sarah Hersey. I am the Director of Collaborative Intelligence here at the WHO Hub for Pandemic and Epidemic Intelligence, and I will be your guide this evening, so you will be seeing me coming up and down throughout the evening. This event is co-hosted by the WHO Hub, and we also want to acknowledge our important partner who is co-hosting with us, which is Charité Center for Global Health. So we have a real mixture of people here in the audience, which for us is really exciting. As a public health organization, we often just end up talking to ourselves. And a lot of the reason for being here is to bring different people from different disciplines, from different types of institutions together to talk about issues that are really affecting public health in the world. So today we have representatives from the German government, from diplomatic missions, from academic institutions, international organizations, civil societies, and the private sector. So I think that's a great example of how we have this kind of cross-section of people that don't necessarily always work together, but have a lot of interest in the same issues that we're able to highlight. I would say if you don't self-identify as any of those, my apologies, we can fix this for the next time. So the theme tonight is really looking at how contextual information is the backbone of effective public health intelligence. So we're going to be looking at how different dimensions of contextual information improve our interpretation of the complex interplay between factors that influence health outcomes. So those factors are really diverse. They can be socioeconomic conditions, environmental influences, geographical information, and movement patterns. So we're going to be talking about a lot of these different types of health information. And now is a really important time for that. I think many of you know that WHO last week declared a new emergency of public health of international concern, or a FAKE, for Mpox. So the initial emergency was called in 2022. And we had a global movement towards addressing the Mpox outbreak. And it seemed to be getting under control, but what we've been seeing recently is variants. So new clades that have been introduced, or variants, we're seeing different transmission patterns, we're seeing different populations that are being affected. And it's really important for us to be gathering that epidemiological data, that research data that allows us to understand what's happening with the outbreak. But really, we can't understand how to properly address it without the type of contextual information that we're going to be talking about tonight. I mean, contextual information allows us to understand what are the population dynamics that are driving transmission. What are some of the behaviors that are putting people at risk, and why are people engaging in those behaviors? How do we address those? And what are some of the interplays with health-seeking actions, and how can we improve health-seeking actions? So I think this is a very timely conversation that we're having about how do we build this type of work into what's happening on a daily basis, including with Mpox. So we will be exploring common challenges and enablers in how we use contextual data for public health intelligence. We'll be showcasing country experiences and case studies, and we really mean to encourage meaningful, multidisciplinary collaboration that enhance public health intelligence and decision-making as we face these current emergencies and also as we're facing future emergencies. So with that, we have 4 invited speakers, which we're very excited about. So we're going to have each of them give a presentation on their specialization, and then we're going to invite them for a panel discussion. We will be taking questions online for our panel discussion. So for those who are on the audience, you have a flyer on your seat. There's a QR code on that flyer. So you can use that to put in your questions and answers throughout the evening. And people online have been provided with a digital link upon registration. So we encourage you to do that, and then we will use those to select questions that we ask during the panel discussion. And with that, I would like to invite our colleague from Charité, Nora Anton, who is the Director of Global Engagement at the Charité Center for Global Health, to give some introductory remarks. And just as a reminder, Charité is one of the founding members of the WHO Hub. They are the co-host for the speaker series, and also, really importantly, they're a very important player in the global health ecosystem here in Berlin. So, Nora, please come join us.
Thank you so much, Sarah, for welcoming here. Welcome, everybody. As Sarah said, my name is Nora. I'm the Director of Global Engagement at the Charité Center for Global Health. And I would also like to extend a warm welcome on behalf of our scientific directors, Beate Kampmann and Christian Drosten, who unfortunately can't be here tonight. It's great to see also some colleagues from Charité. Philip will be moderating the discussion later on. So that's actually a nice sign of the ongoing collaboration. So Charité Center for Global Health, for those of you who don't know, the center was founded in 2023 in January as a research and collaboration hub to bundle the activities of Charité's different institutes and clinics, and also other players here in the Berlin and wider ecosystem. This includes promoting interdisciplinary and international collaboration across 11 different themes that we have formed, which include pandemic prevention, climate change and health, and diagnostic innovations. And in most of them, the contextual insights that we will be speaking or hearing more about later on tonight play a very important role. So it's very exciting for us also to be part of this meeting. Our activities also comprise public engagement and networking across these themes and strengthening Charité's institutional partnerships in global health. And again, here we are very happy to co-host this session with the WHO Hub. Our colleagues from both institutions are looking back on very intense discussions about setting up joint programs. And one result is, for example, the Hub's recently launched research prioritization exercise. And we are all also, as I said, also really excited to be part of this speaker series. What we are very much looking forward to is the launching of our new Global Health PhD program in October. So this program is implemented in collaboration with 7 partnering institutions from the Berlin region and supported by the WHO Hub as well in the first instance through guest lectures, for example. And this program aims to train excellent scientists for leadership positions in global health. Thanks to the broad partnership, the program imparts an interdisciplinary perspective on health and also a sensitivity to contextual factors and cultural factors, for example, including affecting health. And then we are also excited looking forward to the upcoming World Health Summit here in October, with activities hosted by different programs and people and initiatives that are also within the Charité Center for Global Health. For example, there will be at least 2 sessions focusing on the EU Global Health Strategy and how this sort of translates or has already translated to innovations in research. And I know that the WHO Hub, you're also preparing some interesting activities there. So with this, I would like to pass the floor back to Sarah. Enjoy the night, enjoy the networking and the talks. I'm sure we're looking forward to a really exciting evening. Thank you.
Thanks so much, Nora. So I'd like to introduce our first speaker. She's going to be joining us online. We'll see if her face pops up soon. So as we wait, I'd like to introduce Esther Hamblion. She is an epidemiologist with the WHO Health Emergencies Program in Geneva, as well as the head of the Public Health Intelligence Unit. Hi there, we can see you. Previously, Esther was in the WHO Africa Regional Office supporting the response to outbreaks with a focus on strengthening surveillance systems for data collection, collation, and analysis to better target intervention activities. Prior to that, she was based in the WHO country office in Liberia, where she led the WHO epidemiology team during the Ebola response, as well as during the recovery and health system strengthening phases. Esther has also worked as a field epidemiologist with Public Health England and brings a huge amount of knowledge to this area. So we're excited to have you speak. Over to you, Esther.
Thank you very much, Sarah. Can I firstly check that you can hear? Because Can't hear online. I can see a nod. That's great.
Oh.
Fantastic. Okay, so firstly, thank you very much, both to the Hub and to Charity for the opportunity to present today. And really my sincere apologies that I can't be there in person. I'm sad I'm going to miss the important networking bit and potentially the drinks afterwards. So I hope there'll be future opportunities there. But as Sarah explained, I lead WHO's operational public health intelligence activities. So this is the day-to-day detection, verification, risk assessment, and information dissemination activities within our health emergencies program. So if we move to the first slide, we undertake these activities as part of our global early warning function and as part of our responsibilities under the international health regulations to support countries in controlling any event that has the potential to cause a public health emergency of international concern. So I'm going to talk today both about our routine daily activities and the use of contextual data and insights, as well as an example of how we scaled up our use of contextual insights during a public health emergency of international concern to support the rapid response activities. But firstly, just to highlight, this map here demonstrates the wide range of public health events that we both detect and respond to as WHO whilst we're supporting countries. And the majority of them don't become public health emergencies of international concern. But currently we have 40 emergencies that we're providing extra technical and financial support to, ranging from infectious diseases to ongoing humanitarian events, as well as sudden onset disasters. So if we go to the next slide, I think many of those in the room are used to these definitions by now, but I thought it was important to show both the definition for public health intelligence as well as contextual insights, because the two definitions really highlighted here show that we can't have public health intelligence without those insights if we think that contextual information is any information that improves interpretation of data. On the next slide, you can see a range of the different data that we use to interpret some of our signals of potential public health events. And credit for this slide goes to Isabel from the Hub. These range from socioeconomic factors, demographics, land use, climate, human mobility, political insights, to name only a few. This is just a few of those factors there. And most of the time, we have to go to different sources to access this information. It's not nicely packaged for us. And when we access that information, it's also often not available at the geographical level that actually aids our interpretation of a potential public health event or a signal. And also to stay on top of where these sources are is obviously quite a mammoth task. So we go to the next slide. One of the keys for us to gain contextual insights in WHO is really that we are a global team. So as well as the small number of people, both in Geneva and Berlin, we have 6 regional offices across WHO. And then importantly, the 153 country offices that work very closely with the national counterparts. And we also have access to a network of different technical experts, whether they're in laboratory, in animal health, at the Food and Agriculture Organization, and having that ability and the relationships to be able to access that vast network with speed is really important for us in understanding the contextual information that we're talking about today. So we go to the next slide. So a little bit about our routine processes. We detect thousands of raw signals, potential public health events, which are triangulated with contextual information and data in order to determine which we want to follow up as an organisation and which are key to our activities as WHO in protecting global health. We follow a standardised set of processes to support the notification of these events and the response to them. Following those steps I mentioned previously of detection, verification, risk assessment, reporting, and then response. And I've tried to highlight on the diagram on the right-hand side in yellow, where we use contextual data and insights that feed into our decision-making process. So in the very top box, we start with the data and information that feeds into us as raw signals. And the first step involving contextual insights is that triangulation step where we compare that raw information with other informal as well as informal sources, as well as looking at basic contextual information around, for example, the population or the geography that an event is occurring in, as well as the previous trends or occurrences. And this is normally done at an individual public health analyst level. And within our team, they then post something that they think is a signal of importance for the input and the wider contextual insights for the wider team. And we triage this information through a daily meeting, which is a multidisciplinary meeting where we determine how to categorize the signal. And in the time between the public health analyst finding the signal and us having the daily multidisciplinary meeting, people are searching for that contextual information to try and better understand that signal. So is it something that's abnormal for that time and place? Whether there's been potentially reports of sickness in animals in that area, what the political context is, what's potentially happening in neighbouring countries, what the cross-border movements are, etc. So there are many different contextual insights we consider at that stage before we determine that we need to move to the next step, which is verification, when we follow up with the member states on the potential signal, and they provide further contextual information, which is often in the form of the clinical information, if it's a small number of cases, laboratory results, what the access to healthcare is, and medical countermeasures. And then the last part of our process is when we've determined that it is an event, and we want to undertake a more detailed risk assessment, or what we call a rapid risk assessment, to better understand the situation and to determine what level of support is required by a country. And one of the key sections of this assessment is a context assessment. And we've actually been working with colleagues at the hubs on better ways that we can visualize that contextual data for risk assessment so that it enhances our data and decision making. There's quite a lot around that, but we haven't got time to go into it today. So I'll move on to the next slide. So I wanted to summarize a little bit about what some of our routine activities were, but I also want to talk a little bit about how we use contextual data and insights during a public health emergency of international concern. And this is something that we implemented during the COVID-19 pandemic. So we developed a public health alert system using a mixed methods approach, which combined both epidemiological information with contextual data and assessment to really allow for that additional insight to the extent of the pandemic and to support the identification of countries where immediate actions were needed to mitigate the surge of morbidity and mortality that was being seen. So the output of this was in the form of a global operational watch list, and it informed and supported resource allocation, advocacy, as well as the critical assistance. So you can see here in the diagram that it was a three-stage methodology. The first stage was based on the time series of cases and deaths as reported to WHO by countries, with a metric of interest being the predicted number of true COVID-19 associated deaths. And this was obtained by correcting the projected reporting figures using an adjustment factor. And key contextual information was used to develop that adjustment factor. For example, some of the inputs were World Bank income groups, consultations with those in country, to be able to adjust those factors based on the knowledge about how the fatality rates in particular countries actually translated into hospitalisation and public health burden. The second stage in the middle on the diagram there was involving the inclusion of contextual information for each country to complement the data from the indicator-based surveillance. So the contextual factors were manually assessed using signals from each country based around three key areas: the pressure on the healthcare system, other concerning epidemiological signals, for example, changes in test positivity rates, and factors affecting the response, which may impact the functioning of surveillance systems, such as civil unrest, and the capacity to implement public health and social measures. So if we move to the next slide, this contextual assessment was implemented within a Bayes classifier framework where points were assigned to each of the indicator levels and thresholds were set for upgrading or downgrading that initial alert threshold. And then to account for the fact that the information used for the contextual assessment was very heterogeneous, the points were further augmented using a level of trust to categorize uncertainty into the assigned points. So this approach was designed and implemented to standardize a decision-making process using a lot of different data sources while still trying to maintain the qualitative nature of the contextual assessment. We move to the next slide. As I mentioned earlier, the key output was in the form of a global operational watch list, listing countries by if they were of high, very high, or critical concern. And this weekly analysis informed the release of operational and technical support. And actually, we could directly link this to the fact that nearly 500,000 rapid antigen diagnostic testing kits were sent, over 6,000 oxygen concentrators, as well as support to deploy and establish treatment centres. And importantly, the system was also used as well as the evidence basis for the release of more than $27 million from the WHO Emergency Fund, which obviously helped to expedite response activities. So next slide. So to conclude, because although I think I've been talking quickly, I think I'm running out of time. I hope that I've described two different ways which we harness contextual insights with public health intelligence in the WHO Emergencies Programme, both using daily qualitative approaches and then during a more specified time using a mixed method of the qualitative and quantitative approach. But these are very complex factors, and I think this causal loop diagram for the COVID-19 pandemic really nicely represents that interconnectivity between the health, the economic, the social, and the environmental aspects, and that they're multi-directional. And we really do need a lot more work in this area to have the data pipelines and the analytics that are really needed to support the harnessing of these contextual insights with the epidemiological data. And this overall will help us to better support our response to outbreaks and emergencies. Thank you.
Thanks so much, Esther. I think something that I always take away, and this isn't the first time I've seen this, but I'm always struck by really just the sheer number of emergencies that are happening globally every single day, and many of them that you can't see as clearly are concurrent in the same countries, and the pressure that is on countries to be responding to them. As well as, I think well shown, it was the sheer amount of contextual data that's out there that can help us bring this in, and the number of raw data sources that are being analyzed on a daily basis. And so I think really very useful to look at how do we more systemically or actual data to assist us in making decisions on a timely manner, country by country. So with that, thank you. I'm going to introduce our next speaker, which is Haley West, who is with us in the audience. And Haley is currently the International Organization for Migration's Senior Program Officer for Health Emergencies within the Migration Health Division. Haley supports the coordination and provision of technical and operational guidance for IOM's health response to humanitarian and public health emergencies globally. She also supports capacity building of IOM health teams in humanitarian and public health emergencies, with a particular focus on harnessing IOM's comparative advantage around understanding public health programming through a mobility lens. Haley has over 10 years of experience working in the space of humanitarian public health emergencies, and we look forward to hearing from you. So please welcome.
Thank you, Sarah. I hope everybody can hear me online. I brought my cheat sheets with me. We can go to the next slide. So we're here to discuss how to harness contextual insights for better public health intelligence. And in this case, I want to speak to how an understanding, I can control, how an understanding and application of population mobility can be used to enhance preparedness and response. And this slide really is sort of my summary slide, looking at how we try to understand population mobility and its critical relationship for public health preparedness and response. We look at mobility as a social determinant of health for migrants, and when I talk about that, I'm looking at it from an individual level, that the health of migrants is affected by the circumstances of the migration process. We don't see that mobile populations are more inherently more vulnerable or exposed to health risk, but rather it's the conditions of the migration process, how they travel, how they are treated, what is their access to healthcare services that really can influence the health risks that they face. We also look at mobility as a contributing factor to the transmission of diseases. So we look at a population level, an increasing volume, rapidity, and ease of travel can impact public health at a larger scale. And as mobile populations interact with host communities, this is also part of that contributing factor to the transmission of disease, both within countries, but also across borders. We also look at it from a predictive factor as to the spread of diseases, which I think I sort of already mentioned. And we look at how we can have mobility-sensitive responses to target high-risk locations. And I'll get into that a little bit later in my presentation on what are the methodologies and what are the tools that we're using to be able to do that. And then, of course, the integration of mobility information into disease surveillance and response mechanisms, we believe as IOM, and I think that's what we're here to discuss today, as one of the contextual factors, increases the effectiveness of a public health response. So today we see that a health threat from a communicable disease, for instance, in one location can eventually pose a threat everywhere due to the interconnectedness of our world through travel and trade. And many of these risks are exacerbated by unprepared public health and broader health management systems. And so we really push for a well-coordinated, system-wide, multi-sectoral action to be needed to make sure that we have systems that can respond to these types of threats. So I'm going to go into what's called IOM's displacement tracking matrix. This is our tool, our team, our methodology that we use to gather information around population mobility. And so as the UN Migration Agency, we work to support partners with access to data and analysis on population mobility, including as it relates to displacement, whether that's internal or across borders. And so DTM really looks at gathering and analyzing data on mobility, but also vulnerabilities and needs. So you can see from the slide here, in terms of who we gather data on, the populations involved include internally displaced persons, returnees, migrants, the locations. These are just examples, but it could be a displacement site, transit points, places of resettlement, places of congregation, which is something important to us as public health practitioners. Mobility flows, so those could be internal, cross-border, spontaneous, organized, looking at different mobility corridors, for instance, that are important to us from a public health perspective. Needs and vulnerabilities, as well as the conditions. So when I talk about conditions, it's not only just about the infrastructure or maybe the livelihoods of the migrants themselves, but also the modes of travel, which is really, really important when we're trying to think about this from a public health perspective. So in terms of the methodological components of DTM, there are 4. I'm just going to go through them very quickly. We have mobility tracking, which looks at tracking populations both internal and across borders. We also have flow monitoring, which look at specific flows, which can be also at, for instance, that might be relevant for us at points of entry or other border crossings or other points of congregation. There's also registration, and also surveys are a part of the methodologies that we have as part of IOM's DTM. And we use these different methodologies to be combined together to produce information and analysis on population mobility and displacement. We also look at the use of other types of sort of bigger data to complement the data that is gathered and analyzed by DTM ourselves. So for instance, call-derived records is another tool tool that we've used for mobility analysis. So this slide just very quickly sort of shows you, if you can see, it might be a little bit low for those of you in the room, but you can see the spike in the mobility or in the displacement when this is from Haiti, and so this is from, there was violence that started on the 24th of April, and you can see the sort of the spike of where people moved based on their cell phone records. And then you see that the spike goes down starting the 6th of May, when the situation has calmed down. So this is generally useful for acute events like conflict or disaster, but there's limitations in terms of the speed of the data. You have to have agreements with providers for that information already. So again, thinking about some of the challenges when we're looking at trying to analyze population mobility in an acute emergency, this is one way that could be used, but there's also limitations. Another thing that we've used is social media. And so we use this in Ukraine with the displacement. So again, just another example of a tool that we've used for mobility-sensitive public health intelligence, where we basically were able to use social media location logins to show the displacement of population during the first part of the Ukraine crisis. Oops. I have to click through this. So I've talked a little bit about the data piece and what kind of data do we have, or the data side, but really how does this relate to IOM's preparedness and response efforts? How do we harness data not only for public health intelligence, but also for operational decision making? And this is really, I think, the crux of what we are trying to do here. IOM has what's called the Health Border Mobility Management Framework, and I won't go into so much detail, but I just wanted to highlight that we have this umbrella framework, which is our conceptual operational framework that guides the work that we do in public health, and particularly as it relates to public health emergencies. And this framework, for instance, is currently being used in our ongoing response to MPOX at the regional level. So you have 5 different strategic objectives, and I'm just going to hone in on strategic objective 1 because I think this is the most important for this discussion, where we look at how do we enhance the evidence based on human mobility dimensions of communicable disease to inform effective prevention, detection, and response. So we've got different core activities, and I'm going to go a little bit into the second one, which is called population mobility mapping, as a next point. So the aim of population mobility public health analysis, as you can see on the screen, is really to look at how we can support decision makers to tailor the recommendations for preparedness and response interventions according to the context that we see on the ground. So PMM, or population mobility mapping, is one of our specific methodologies, and we use this set of tools to help us understand the population mobility dynamics and characteristics, and in order to inform prevention, detection, and response efforts. It can be used actually in both a preparedness setting as well as in a response, and I'll give you some examples of that in later slides. We look at both origin and destination, but we also look at the routes that people take. Those mobility continuums, or those mobility corridors is what we call them, because they're very important to understand how, not only just how people are moving, but how are they connected? How are these communities connected? When we think about traditional sort of surveillance or intelligence around diseases, we think about how the disease is transmitted in terms of, is it, a bacteria? Is it a virus? How does it, but we also need to think about how do, as Sarah said, what are the behaviors of the people in these communities at an individual level, but also at a community level, and how are these communities connected, particularly across border when we think about the international health regulations and the importance of that. So we want to look at sort of origin and destination points and links to outbreak areas. We also want to, and this also helps us to think about not only response areas, but also readiness or preparedness areas, because in an outbreak response, as many of you know, we look at different interventions based on how that particular area is connected to the outbreak area. We also look at key transit locations, points of entry in particular, and I think I'll get a little bit more into that in a bit. Characteristics of the mobility, the demographics, the reasons for travel, and then of course the health system information. So what is the capacity of the health system in these particular areas, border communities? How are they linked to the points of entry, and what is the health capacity at a point of entry, for instance? What are the needs? And so so basically it can be applied in different phases of the outbreak. And at different phases, you would also look at different interventions related to that. So maybe in a readiness area, you might be looking at how do we identify locations to enhance infrastructure or national capacity building efforts or even stockpiling. Ooh, I gotta move on. I'm going to keep going. So the 3 stages of population mobility mapping is participatory mapping exercises, site evaluations, and population flow monitoring. So this is how we do population mobility mapping. It's not rocket science necessarily, but it really does garner important information that can aid decision makers. So this is an example from DRC in 2018 to 2020, the Ebola outbreak. And what I love about this map is that it really showcases how we look at different mobility corridors, how they are connected to the outbreak area. So the area that is in a square is Beni. That was the original it was the original place of the outbreak for Ebola. And basically what we went in and we did is this mapping to show how populations were moving in and out of that outbreak area. And not only within DRC, but also to Uganda. And this really assisted the response in being able to identify where do we want to prioritize public health interventions, because we know as public health practitioners, we never have enough money to do everything. So we really had to look at, what are the points of entry that we need to prioritize? What are the communities that we need to prioritize? How can we assist the response to say, okay, we need to start vaccinating healthcare workers in Butembo, because there is a cattle trade that is quite strong between Beni and Butembo. And we need to be able to, we believe that the transmission may start to head towards Butembo very soon. So this is just one example. I also wanted to show you from the recent Uganda cross-border exercise. And again, we were able to use the map from DRC to actually, as a baseline for what we did in Uganda, because we already had that. And the key takeaway here that I want to emphasize is that at the beginning of the outbreak in Uganda, DRC was actually considered by WHO as a priority 2 country in terms of readiness. But after our mapping that was done and we were able to analyze it, WHO actually changed their rating to priority 1 because of the fact that we were able to show the connections between Uganda and DRC were very strong. And so this is, again, just shows the practical and operational nature of these exercises. This isn't something theoretical. It's really looking at how we can contribute through the mapping and the understanding of population mobility to a response. I just have 2 more slides. In terms of flow monitoring, so I was talking about population mobility mapping, the participatory mapping aspects, but also I think it's really interesting to see how flow monitoring, which is another methodology that I spoke about at the beginning, has been really useful in terms of public health surveillance. So this slide analyzes how mobility data, in this case flow monitoring data, can be used to predict risk of disease transmission. So again, it must be emphasized that the word the word risk is important because we really don't want to stigmatize migrants or other types of travelers. But this shows how flow monitoring data corresponded with the transmission of Ebola, in this case, during the West Africa outbreak. So you can sort of see where people were coming from, where they were going. This was based on the flow monitoring data, and then we can also see the corresponding spread of Ebola. And then my last slide is just, I've talked a lot about sort of response and preparedness, but I also wanted to show that this methodology is also being used for preventative purposes. So we're actually piloting the use of PMM and understanding of population mobility in Afghanistan to look at how do we reach either zero-dose children or underdosed, under-vaccinated communities. Because again, I think the application of this is so possibly huge in terms of how we start to integrate it into our public health toolbox and the knowledge that we're using to be able to enhance our efforts as it relates to both public health intelligence, but then very importantly, the application of that, which is the public health operations and programming. So I'm going to end there. Thank you so much.
Thanks so much, Hallie. I think really importantly, just framing this as the impact of mobility, both on individuals and their vulnerability, but also the impact of mobility on populations and the potential for it to affect disease transmission. So thanks so much for highlighting that. I think also very taken by the complexity of the type of data and again, the sources of that data, and how do we really interpret that? So the application of, I always like the implication of a practical framework rather than a sort of a theoretical framework, but a very practical framework for analysis so that you can really drive real-time decision making. So appreciate that. And now I'm happy to introduce our next speaker, Sophie Mower. Sophie currently leads strategic partnerships at the Humanitarian OpenStreetMap team, or HOT, which I think is the best acronym for an organization, to enhance the creation, management, and utilization of open map data and support impactful decision making. She has over 20 years of experience in international and community development and has worked with HOT since 2020. Her passion lies at the intersection of people and technology, utilizing her skills in human-centered design and design thinking to craft programs tailored for lasting impact. Sophie's experience spans from establishing a makerspace at the Bahir Dar Institute of Technology in Ethiopia to co-founding the First Steps Project, which is a UK-based nonprofit that provides workshops and training programs for young people in deprived areas. Welcome, Sophie.
Thanks, Sarah, and thanks so much to, first of all, to everyone for being here, and also for the Charity and Pandemic Hub for inviting me. And just to clarify, 12 years experience, not 20, gave me 8 years on my age. So I'm going to be talking from an NGO perspective, so a little bit different to the previous two presentations. And I'm going to talk about how community-owned data can impact and enhance public health intelligence. So I am from the Humanitarian OpenStreetMap team, and we are an international NGO which envisions a world in which community needs are addressed through mapping. Everyone can access and contribute to the map, and open map data is available and used for impact. We work in 94 countries across the world through 4 regional open mapping hubs, and it is our goal to map a home to 1 billion people that are not already on the map, believe it or not, by mobilizing a community of 1 million volunteers, and I'm going to talk about how we do that. But first, some definitions. So when I talk about open data, I'm talking about data that is built by a community, contributed and maintained by, and also known as citizen-generated. Mapping, I'll talk about that a lot in the next couple of slides, but it is the process of building the map. OpenStreetMap, quick show of hands, who has heard of OpenStreetMap? Oh, great. Okay, cool. That's not normally the response I get in the room. But OpenStreetMap is essentially the Wikipedia of maps. It's a free editable map of the world that can be edited by anyone, anywhere. And finally, participatory mapping, which is the convening of multiple stakeholders to build a map that is inclusive and representative, and accurately documents the realities of the people that are living in the locations that we are mapping. So when we look at OpenStreetMap, often there is a kind of big blank space in many of the areas that we look in. So to start off, we need to start filling out that space. And we do that by using satellite imagery or drones or UAVs to capture imagery of the location. And then we start tracing over the building infrastructure and the road networks to create the base map. Then we start adding the local data. This is where we add village names, the names of cities, neighborhoods, etc. And then the next phase is the mapping of facilities, so schools, health centers, community centers, shops, etc., etc. And then we start adding the microdata, which is the information that really only local people that are living in these areas have the information about. That is, what are the opening times of a specific clinic? What is the building made out of that clinic? If there's a big flood, is it going to collapse quickly? So that's where we really get that kind of microdata to enrich and complement the map. So we're not saying that open maps need to be a standalone. We're saying that they can be enriched and complemented by existing data sets and data sets that we can build out collectively. So the humanitarian OpenStreetMap team has a tech team. We have a great tech team who maintain and contribute to different types of open mapping tools to enable that map to be built. Depending on what kind of data you need to collect, you need a different type of tool to collect that data. And all of the data that we collect and all of the tools that we use are accessible, they're free, and they are online, which means that in very resource low settings, where you don't have a lot of connectivity, you're able to contribute the data as and when you need to. Lots of governments around the world have made a commitment to open map data, but very few have the know-how and the confidence to actually extract and use that data in a public health emergency. So, what drives our approach? So humanitarian OpenStreetMap team, we really do look at the community element of the data, and we don't kind of conform to the traditional mechanisms of data collection. Often that process is upfront, it's one time, it's static. After you've gone out and collected all of the data, it comes back, it sits in a database somewhere, and then you need to do that same thing again when you want to collect another type of data set. What's interesting about our approach is that rather than investing in the data collection itself, we invest in building the capacities of local people to own their own data. This approach is scalable. It means that we can digitize. It means that data can be reused again and again, and I'll give an example of that in just a moment. And most importantly, investment in the community to add their own information about the existing infrastructure means that they're more aware of their own risks and the own vulnerabilities of the environment that surrounds them. So, as I mentioned, we work in 4 regions across the world, 94 priority countries, one open mapping hub in Latin America and the Caribbean, one in Western Northern Africa, one in Eastern Southern Africa, which is where I'm based, and one in Asia Pacific. So I'm going to use the same example as Hayley around making maps for Ebola contact tracing. So we were working in North Kivu and Ituri provinces in DRC and looking at how transmission was happening coming into Kisuru and Zombo in western Uganda. Now, we knew that it was happening because there was an increase of prevalence of the disease in Western Uganda, but we didn't know quite how it was getting there. So we used 2 methodologies to try and get the data to understand where those routes were going from A to B and what kind of landmarks were in those localities. So we used remote mapping. So we had a bunch of volunteers sitting offline, drawing lines over satellite imagery, and we had community mapping of landmark features that were on motorbikes. So the motorbikes were used because they're able to get over lots of different terrains, and the community health workers who were trying to understand where patients were and where they were moving to were able to sit on the back of the motorcycles and start really knowing where they were in terms of relationship to the environment around them. We put 2.5 million building footprints onto the map, and the community health workers were trained in how to collect the data, update the data, and now we've got a live map that is really owned by those community health workers. Then those maps were printed off and handed to local health workers who then would not necessarily need their cell data to be able to see where they were and were not patients who were living with Ebola. So what that meant was that the immunization efforts were strengthened as a result of that kind of very community-owned data. Second example I'm going to use is our response for COVID-19 in Peru. So there are, in the Cusco region of Peru, there are 1.3 million people living in this area, but it's very mountainous. There's lots of jungle. It's very difficult to know where communities are living, and as a result, many communities are actually completely missing from the map. So there's not any... So when the government comes to plan their response, it was really difficult for them to know who was where and how many was where. So you can see here, over 2 months, we built out the map. Orange is the blue, is the buildings, and blue is the roads. And over 2 months, we were able to mobilize 10,000 volunteers to map this whole region. Again, we did this remotely. And then the data started being used by lots of different actors without much input from us. So this map here was a dashboard that was prototyped, and the community members themselves started adding where hospitals were getting overflowed and where oxygen then needed to be distributed across the city of Cusco. So the community really took it upon themselves to help out with the response. The other thing that happened here was that there were 900 oxygen tanks taken to community members who were not hospitalized. So this dashboard actually helped with the dissemination of that as well. And it meant that the government were able to see where the areas of transmission were more likely to be based on things like how busy was a market. Again, the community was uploading that kind of data to this dashboard with very little input from an external audience like ourselves. So those are my 2 examples. We are always looking for partnerships. So if you are interested in how community-owned data can impact the work that you are doing, please come and talk to me. I'll be here for the next half an hour. No, longer than that. hour or so. We can work with you in a variety of different ways. So we can help to develop large-scale data sets. We can provide training in using open data for public health intervention. We do lots and lots and lots of innovation around AI, drone mapping, creating open source tools for community members to not only contribute to themselves, but also use to add to the map themselves. And also, we do a lot of field mapping work as well. So if you need a response quickly, we can help you do that. Yeah, that too. So I'm going to stop there. Thank you so much for inviting me, and come and chat to me at the end of the session if you'd like to hear more. Thanks.
Thank you so much, Sophie. I immediately reacted to that number of 1 billion people not being mapped, essentially, and was wondering what the impact is on IOM's work in trying to actually trace mobility if you don't have people mapped. And also, just the fact that you're using open sources and that community ownership to build that mapping for anybody that's done emergency response, particularly in low resource settings. Getting that type of community information is really difficult and very, very critical to making those types of decisions, like how do you do distribution of oxygen. So I'm happy to now introduce our next speaker. Our next speaker is Mohammed Jallow. He is going to be with us online, so we'll wait for him to pop up. Mohammed is the founder and chief executive officer of Focus 1000, a leading national non-governmental organization in Sierra Leone that is dedicated to transforming social and traditional norms to enhance opportunities for vulnerable children and their families across the country. Mohammed has 50 years, and actually that number is correct because I've known him not for that long, but we know that Mohammed has 50 years of experience in this area, including with the government of Sierra Leone, UNICEF at both the national and the international levels, and with Focus 1000. He's participated in the only 2 global disease eradication campaigns undertaken so far, smallpox and polio, and he has also played crucial roles in the fight against Ebola and COVID-19 in Sierra Leone, especially by developing strategies to engage religious and traditional healers. In 2017, he was awarded a member of the Order of the Rokel by the President of Sierra Leone for his services to the country, especially during the Ebola epidemic. I personally am happy to introduce him and privileged to now know 3 generations of the Jallow family. So welcome, Mohammed.
So, thank you very much. No, unfortunately, I cannot be with you on that side, but I'm very happy to be here. I really appreciate the opportunity of being invited, to take part in these very important sessions. Like Sarah says, I have 50 years of experience. It means that in fact I'm retired from the active service, from the UN. But our motto in Focus 1000 is retired but not tired, so that we can inspire before we expire. So even though I have my 50 years of experience, I still want to continue. Next slide, please. Yeah, so I as I'm so happy also that I'm doing this session immediately after Sophie's session that is talking about the role of communities, because in Sierra Leone, for example, we can see that Sierra Leone shares a border with Guinea and Liberia, and we have a lot of cross-border activities. Sierra Leone was affected by the Ebola in 2014 and 2016, COVID-19 in 2019 and 2021. But in addition, we also have periodic, outbreaks of Lassa fever, rabies, anthrax, salmonella, and now, mpox. So, but the good thing about Sierra Leone is that, the government has been able to develop the One Health communication strategy, also developed the National Public Health Agency, and passed, the Public Health Act in 2021. Also, good efforts are going on by the government and partners to strengthen, the health system. Next slide, please. But the interesting thing, especially if we talk about, contextual context, in Sierra Leone, is to see how religion plays a major role, in public health. If you look at Sierra Leone, about 70% of the population are Muslim, about 21 are Christians, and one or so, other religion. But the interesting thing in Sierra Leone is religion permeates every facet of our society. Even when you go to the courts, they would give people, to use the Bible or the Quran to take their oath. If we go to naming ceremonies, social events, people would be asked, to do Muslim prayers and Christian prayers. And the interesting thing, unlike other countries, is the religious tolerance. Where I am a Muslim, for example, but I went to a Christian school. You have Christians who are married to Muslims. So there is this religious tolerance which allows people to live as one, not using religion as negatively, but using it to promote a lot of good things. The vast majority of the people have a strong belief in divine protection, as you would see later on, even during the war, during the Ebola epidemic, during the mudslides, during COVID, those events bring people even closer to their maker. Next slide, please. So you would see during the response for COVID-19, Focus 1000, we did series of studies with the support of CDC, UNICEF, and the Ministry of Health. It was very interesting to find out that one main reason why people did not feel that they had any risk, they didn't perceive themselves as having any risk to COVID-19, is that they say they believe in God. They believe that if they believe in God, then God will protect them. So in fact, there is no need for them to take protective measures, which from a public health perspective, is a major challenge. But if you don't understand it, then you begin to blame them that, they are not, the people are not participating, they are not supporting, they are not cooperative. But then because we were now able to go in and understand where they are coming from, so the same religion that they were using as excuses, we also try to see how we can work with governments and partners to use the same religion now, as a positive channel, to get to them. So what I'm saying, most times people are easily ready to blame communities or to use tradition and religion as part of the problem. But what we did in Sierra Leone was to now see how we can use religion and tradition as part of the solution. Next slide. So belief in spiritual and traditional healing, it's very interesting in Sierra Leone. A good number of the people believe in tradition, they believe in spiritual healing. So even during Ebola, some traditional healers came out and said, if you wash with salt water early in the morning, you will be protected. And you want to see how many people got up very early in the morning. Even scientists, got up, technicians, health professionals, got up early in the morning to wash because they believed that by so doing, they'll be protecting themselves. So traditional healing is part of our culture. Traditional healers are trusted. Most times, even before people go to seek medical advice, they would go through the traditional healers to find out if they should go to the hospital or not, or if they should go to traditional healers. So that is how deep-seated, traditional healing is in Sierra Leone. So there is no way you would succeed in public health if you don't build on those traditional beliefs and practices. Next slide, please. So what do? You know, we now see the importance of collecting information from traditional sources. The mosque, the churches, the marketplaces, the shrines, and of course also, you know, local radios and, you know, local societies. Because, you know, if you don't do that, then you are missing out on majority of the information that will be so necessary for you to be able to develop your strategies. So what we do is to put communities right in the center of our public health approaches. We work with the mosque, we work with the churches, we work with market women, traditional healers, women leaders, youth leaders. And let me tell you, even during Ebola, when people could not go out, these channels were actively used to collect information and disseminate information. Next slide, please. So it's not only with Ebola, but the experience we gained, you know, through Ebola, we now use it to form what we call the Combra network. That is the widest and most effective community channel in Sierra Leone today. That network has religious leaders, about 6,000 religious leaders have been mobilized to be part of that network. We also have traditional healers. About 10,000 traditional healers are members of that network. About 4,000 market women, traditional chiefs, the media, you know, we bring in social media and traditional media, and of course, civil society organizations. So this is the first time, you know, you are now able to get religious leaders sitting together with the public health departments. They are part of the district health management teams. You know, so they bring in their perspective. It's very active and alive. It's not a matter of going to do studies. In virtually all the 16 districts in Sierra Leone, you have the Combra network, and we bring in the traditional healers and the market women and the religious leaders to be part of the health system. So they are there ready to provide information. So when health workers are planning, they already plan with the perspective of the communities. Because these, traditional healers, religious leaders, market women leaders, they are in the community and they know exactly what is going on. So, you know, actively, by working with them, we are able to get, you know, correct information, but also to dispel rumors. Because we believe that, you know, one way to dispel rumor is to give correct information. Next slide, please. So it's very interesting, you know, if you go to the Bible and the Quran. So what we do, we start first, because hence they believe in religion. So instead of just discarding that, we now sat down and looked at the scriptural messages. So in fact, if you go to the Bible, you will see that Exodus is talking about, you know, how you should be able to promote hand washing. That same message is also in the Quran. If you look at the Hadith number 278, it's there. You know, a lot of emphasis from the Islamic perspective for hand washing. And we all know how hand washing can be a major, you know, intervention in prevention of diseases. You know, Ebola also, we were able to go to the Bible and the Quran. You know, got the religious leaders to go in and, you know, come up with scriptural verses to support the public health messages. So whatever we do now is now linked to their religion, and it's easier now for them to own it. Also with COVID-19, the same thing. Next slide. So what we have done is to do a mapping. I'm so happy, Sophie mentioned, you know, how you could use community mapping to collect, you know, public health messages. So what we have done now is to map all these members of the community, the religious leaders, the market women, the traditional healers, civil society, you know, and form them into alliances. You know, starting from the community, you know, we have, as I said, about 6,000 religious leaders. You know, 200 traditional chiefs, 4,000 market women, 10,000 traditional healers, and 120 youth leaders, 70 media houses, and 200, civil society groups. So we start the mapping from the community level. We bring them together. They form their Combra network at that level. Then they come to the section level, where they also have their section Combra network. Then that one is also now taken to an higher level at the chiefdom level, where they also have the chiefdom Combra network. Then you come up to the district level, where you have the district Combra network, and finally at the national level. So when you are doing activities, you don't need to go, and look for religious leaders separately, or, women leaders. They are all parts of that, Combra network. And they sit down with health officials, they sit down with agricultural extension workers to plan, so they are involved right from the stages of planning. It's not just at the stages of our implementation. Next slide, please. So what did we learn in terms of lessons? That, community engagement, involving communities should not be like, you have a vehicle and then that aspect becomes your spare tire. It's like most times when we have our vehicles, we have a spare tire at the back. So some people see community engagement as a spare tire in your vehicle. So they only use it when you have a puncture. But our experience is that community engagement should be part of it, 4 tires, if not the steering wheel, so that they are involved right from the beginning of planning, as I'm saying. Then you get all the information. We also were able to learn that the messenger is as important as the message. In public health, usually we talk about the aims, the message, the materials that you use, the media, and all this type of stuff. But we don't usually talk about the messenger. From our experience in Sierra Leone, we now see that the messenger is equally important as the message. And community groups are major forces for local ownership and sustainability. We cannot leave out these community groups, because if you do, then you are missing out on information. You are missing out on uptake of the services. When the ambulances were introduced during Ebola, people did not want to use them because they were scared of the ambulances, until we did effective communication, found out, why they didn't want to use the ambulances, and then supported them, give them correct information. They started using the ambulances, they started using the facilities, and we shouldn't look at community engagement as a one-off activity. It has to be continuous. It has to be built upon, because that is the only way it can be sustained. And the other lesson is that engagement process should be built on existing local structures, as we are doing. The women leaders, the market women, the traditional healers. That is what it should be built on, so that it will be sustained. And effective coordination also between those structures, the government, and other partners, so they are not working in isolation. They are not, parallel systems, but they are well coordinated. And that relationship should be built on trust and respect, and not on fear or suspicion. And finally, that communities, they may be illiterate, they may be poor, but believe me, they have good ideas that they can use to help in promoting public health messages, and of course, in enhancing good partnership. Next slide, please. So Focus 1000, just quickly, we are a non-governmental organization, but a local organization, and we were established in 2012. We have a core staff of about 120, but because we believe in evidence generation and research, we've been able to build the capacity of 120 young people on, data collection, both qualitative and quantitative approaches. And we have a very strong relationship and partnership with the government and other, partners in Sierra Leone and even outside. Next slide, please. So what's our key strategies? 4. The first one is evidence generation. As I said, where we do research to collect information, community engagement. That information is now used to engage the communities. Because, like, for example, during Ebola, people were blaming the communities that they did not want to use the services. But when we did studies, we found out why people did not want to use the services. And one key one, which I found very interesting, was when an old lady said to me, "We are not going to the hospital because your messages say Ebola cannot be treated by medical facilities." That is what we are saying. If you are sick, go to the hospital, but you cannot be cured. So the lady said, "Why should we go to the hospital if we cannot be cured?" Traditional healers are telling us that they have a cure for Ebola, so we go to them. So we now use that information to refine the strategies and the communication messages. We also use the information for advocacy. So we do advocacy as the next strategy, and community engagement is the 4th strategy. The approach we use, we refer to it as the draft and skin approach. Drafts meaning the dialogue, we engage with communities to get their information and their insights and their perspectives, and use that, to promote public health messages. Reflection, where we sit down with communities and ask them, do their mapping, like Sophie was saying, and find out why they are doing the things they are doing, and what they need to do to make changes. Then they do an action planning, where we ask them now to say, okay, fine, with all the information you have, what are the things you want to stop? Why children are dying, why we are having Ebola, what do you want to stop? They list out all the things that you would want to stop. And then what are the good things that you would want to keep? And how can you improve on that? And what are the new things that you would want to bring in? Then we now look at the facilitation. How do we support them? And finally, they also help us to develop key indicators that we can use to measure success. Next slide, please. So these are just our communication platforms, in Focus 1000. You can get it, from the website, we have the YouTube and Facebook. And finally, the last slide. Thank you very much. Thank you, as we say in Creole, and Jaram, as I would say in Creole. Thank you very much. God bless. Over.
Great. Thank you so much for bringing us the gospel of community engagement, Mohammed. I can attest that he continues to inspire and is not resting in his retirement whatsoever. And I think one of the really key points is, a lot of times when we have a public health crisis, we throw, and I can say this as an epidemiologist, we throw a lot of epidemiologists and lab techs at it, even though we say that community engagement is really the critical piece. And each time we have to learn our lesson and go back to that again. And also epidemiologists and lab techs are not necessarily the right messengers for the type of information that we're trying to get to the communities. So the engagement of community leaders and religious leaders in Sierra Leone really did change the course of the response, and a lot of that was due to the work that Focus 1000 was doing. So great to hear that represented here. So now we are going to go on to the panel discussion, and I'm going to invite our panelists back up again, and then back on the screen, as well as introduce our moderator, Philip El-Dua. And Philip is a junior research group leader at the Institute of Virology, associated with the Charity Center for Global Health. He's also affiliated with the Kwame Nkrumah University of Science and Technology in Ghana, and his research focused on the role of livestock and intermediate hosts for the transmission of coronaviruses with zoonotic potential. He's also researching the epi of zoonotic viruses and diagnostic solutions for emerging and re-emerging viral pathogens. He's affiliated with many institutions. I will name two of them, the Center for Research in Emerging Infectious Diseases in East and Central Africa, and the German West African Center for Global Health and Pandemic Preparedness. And I am inspired and tired just describing what you do all day. And I just want to remind everybody online and at your seats that there is a QR code on your flyer if you would like to add additional questions. So please, welcome to the panel.
Thank you very much, Sarah, for the very kind introduction. And also a big thank you to all our panelists for the very interesting presentations that they gave. It's quite obvious the vast array of contextual data that is being used on a daily basis in all of your various endeavors. Now we would like to delve a little bit more deeper into your submissions with some general questions to get your impressions and perspectives, as well as some specific questions that will come in also from our audience. So firstly, I will like to get maybe your perspectives. You have given a lot of information, so maybe in a way of a summary, what you believe the role of contextual information, what role does it play in improving the accuracy and effectiveness of public health intelligence, particularly during global health emergencies where you have a lot of, should I say, surge capacity in terms of the generation of the data, etc. So maybe I start from my immediate right.
Okay. I think it's a great question. I think generally speaking, there's such a runway for the use of contextual data, and I'm talking about mobility and migration data, population mobility movement data, and we really haven't, I think, really tapped into where this could go and the tools and the technology that we could be using. And I think it's great to hear the broad range. And I think what we should really be taking away is that there is no one tool or one technology that's going to sort of be the silver bullet. We really have to look at how these different data sources can be triangulated to improve the response or the preparedness, and how member states and communities, so at national level, regional level, and local level, can be using this information. I was really happy to hear, and I think in my presentation I probably skipped over a little bit, the importance of engaging the power dynamics and the importance of engaging at the local level with those individuals at a community level who understand the mobility dynamics in their community and how that's then connected to other communities. And so maybe I think that there's a lot of scope for us to continue to discuss this and to look at what is the investment that we need to make as a global health community in applying the contextual features, because again, we sort of think of it as we're driving with one eye closed if we're only looking at the transmission of disease traditionally. You probably can make it down the road, but you might be missing something in your peripheral view that you don't see coming. So, yeah, I'll stop there.
Thank you. So not so straightforward. So Sophie, do you have any input on this?
Yeah, I completely agree with everything that Hayley's just said, but I think there's another part of it that I am particularly excited about as somebody who's interested in the relationship between the technology and the people, which is how can we better use technology to create opportunities for like enhanced intelligence. There's so many tools out there. There's so many brilliant brains out there. We're so starting to focus on like open source stuff. I mean, even here in the hub, there's just been the kind of the launch of the OSPO, the open source team, and I met with Samuel and the team earlier today, which was fantastic. But there really is so much innovation and opportunity, especially as we start thinking about AI and machine learning. And I think that there's a real tooling opportunity here for contextual insights, but I just don't know what that looks like yet. So yeah, any tech buffs in the room that wants to talk about that, let me know.
You touched on another point which we will be discussing as
Thank you. Yeah, I couldn't agree more with what's already been said. And I think there's the two different perspectives there. I think in terms of when we think about the local contextual information, it just made me think of a couple of years ago, there was an outbreak of Marburg disease in Equatorial Guinea. And we often very traditionally count the cases and deaths, the hospitalizations, but actually most people were attending traditional healers. So we weren't seeing the people, we weren't counting those people that were actually going to the traditional healers. So we're missing out on a lot of information. And until we knew that contextual information, until we had the people that were working locally on the ground, we were missing all of that data, all of that information. So I think it's really important, the contextual information for improving the accuracy at all levels of what we do. And yeah, the same as Sophie, I'm really excited by how we can use AI and machine learning to improve on all of these aspects. And we'll go into that a little bit more later then. Over.
Thank you very much. It's Mohammed. Mohammed.
Yeah, thank you very much. I mean, just to emphasize that, communities have to be right in the middle of our interventions. Because most times, the diseases start in the communities, they end in the communities. The communities know exactly, where the sick people are. The communities can decide to hide, like in Syria. I don't know what they did when during Ebola, they would bury these people, and plant potato on the graves. So you don't even know them. But by working with communities, they'll be able to get a lot of information. But the thing though is that working with communities, it takes time. But most times, donors do not have the patience. They want everything to be done, by the end of this period, deadlines and all this type of stuff. So we need to be more supportive to community initiatives. We also need to have time to be able to go in and do deep engagement so that we are able to get correct information. Because let me tell you, rumors thrive where there is misinformation. If there is a communication gap, then the rumors will just fly. But then if you work with all these community structures and you are able to get the right perspective and provide the correct information, then you'll be able to debunk most of the rumors. And finally, we must also understand that engagement is not a one-off type of stuff. I hear people say we have sensitized the communities, we have mobilized the communities. No, it doesn't start and end. It has to be continuous. So it has to be nurtured, it has to be supported, it has to be sustained. So I'm so happy that now we are talking about localization. How do we provide support for community engagement? Because it's a two-way. We can get the information from them, and then we can also engage them and support them to be able to disseminate the information. Thank you very much.
Thank you. So it's essential to have the right infrastructure for strong community engagement there. So there was a point that was touched on by both Sophie and Esther, which was use of technology and new approaches. In this regard, there's also how, for instance, is how do you envision the future of public health intelligence evolving with the increasing availability of diverse data sources? There's also novel data sources, and some very promising data sources, for instance, like the use of wastewater surveillance, which came up quite recently. And how do you see the role of this type of innovation in the total evolution of the field of contextual data applications? So, I mean, let me start with you again, Sophie. Yeah.
I don't know where to start with answering that question because there's so many. I think for from a kind of community like development perspective, when we let me formulate my thoughts. Esther, go ahead first. I need to formulate both. I've got all sorts buzzing around in my brain, so let me just write them down, and then I'll go next. Sorry.
Okay, no problem. So,
happy to. But yeah, I think this is such an exciting area, and I think this is possibly the right room of people to be in for this. I think there's a lot of collaborations that are being started at the moment that will help to improve how we not only collect the information, but how we combine information and how we access that information. I think at the moment we're slightly overwhelmed with the amount of contextual data and information that's out there. And it's only when we start to use sort of new technologies and AI that we'll be able to properly interpret this data. And I think there's always going to be that human element there, that we need to be able to have the training and the background and experience to interpret different data sets and how they're combined together. But it's absolutely key that we leverage any of these technologies that are there so that we have more timely information, which then enables us to have a more timely response, which is what we're always aiming for.
Thanks for bearing with me there.
Yeah, no problem, Sophie. So you feel free to jump in whenever you're ready.
Sure. My brain was swinging from the safety and the misinformation all the way through to other things. So I think from a kind of community safety perspective, we need to make sure that we're using AI and ML responsibly, and that's something that we don't at the moment have the networks and the infrastructure to do yet. I think it's coming, but it's coming from big tech. It's not necessarily coming from us as kind of humanitarian sector. So I think it's really important that, as Esther said, that we connect and we collaborate and we work together to make sure that there is good policy around how AI and ML is rolled out in a kind of in a community setting. And then the other thing that I think is really exciting, if we think about kind of foresight trends, is the kind of concept of like synthetic audiences, like being, making predictions about how people are moving, how individuals are interacting with the information that they're being provided with, and I was on this is a side note, but I was on a webinar the other day, and this team from Good Innovation were talking about how they were creating these synthetic focus groups to understand better how their audience might respond to certain pieces of information. And I just think that opportunities like that, where you've got like an audience right at your fingertips without, needing to go out into the field and understanding the trends, is really exciting. So thanks. And thanks, Esther, for saving me there.
Yeah, very interesting propositions. Do you have anything to add, or we skip this one for the next one?
I think let's go on. Let's see what other questions we have.
Yeah, so now there's another theme which I also noticed among the various presentations that you gave, and this has to do with collaboration. So in our field, for instance, we do a lot of collaborations with different disciplines when we want to study specific diseases that affect certain communities. And again, Sophie also put out the call at the end to talk to people who wanted to collaborate, for instance, in providing services and data for the aspects of the work that they do. So I want to ask a general question also to the panelists here. In what ways can international organizations and NGOs such as Focus 1000 collaborate more effectively to harness contextual information for better pandemic preparedness in the future? This time, probably I will start with Esther online.
Thanks very much. Collaboration is key to everything we do, whether we're working with public health intelligence data as we are more at the international level, or whether you're working with communities. I think collaboration is essential to harness that information and to get that multiple stakeholder viewpoint really into the contextual data and information, because seeing something flat on a piece of paper does not give you the context. You really need to understand the situation locally where you actually want to apply your response mechanisms. So I think I showed that we have quite a large network of people, and for us, when we want or we need additional information, we put out calls through some of our networks to try and get a little bit more contextual information to better understand the situation. So I think more collaboration, the better from our side.
Thank you very much, Mohammed.
Yeah, I think collaboration, is collaboration. There is no end to it. Because believe me, when you take the international partners, they have the resources, they have a lot of, experience and technology. But then now you look at the local partners, they have the reach. Local organization can get, to the last mile. So if you have this collaboration between the international partners and the local partners, you are able to bring resources right down to communities where they are needed. You are able to bring technology. For example, you are talking about AI. When in Focus 1000, we worked with the government to improve on data collection and reporting. And believe me, the timeliness can be improved, by technology. The completeness of the data can be improved, but most importantly, the accuracy of the data. There is a lot of information which, by the time it gets to the Ministry for Utilization, it is already old. It may not be complete. It may not be accurate. But then international partners can come in with that support of technology to enhance the speediness of the data collection and reporting and the accuracy. For example, there is now scan form, which can enhance data collection and accuracy. But also, how do you get the feedback loop so that you are able to now not only collect data for the sake of collecting data and transmitting, but then you are now able to utilize data at the community level. You are able to get back the information to the communities, to know where children are not being immunized, to know where you have the zero-dose children, zero-dose communities, that can help. So I see working together as the most powerful, aspect of what we are doing. Over.
Thank you, Mohammed. I think Sophie wants to jump in here.
Yeah, I do. Thanks for Mohammed for that. And couldn't agree more. And just to add what you were saying is that it's not just the data collection as well, but also the data storage and management. And I was kind of smiling, Esther, when you mentioned earlier that you're having to leverage like multiple different data sources to be able to try and triangulate and make decisions and then get the information out there. And I think we have very much the same issue. I was working with a community in Mozambique a few weeks ago, and we had the government officials that were saying, "Oh yeah, I've got some of that data on my hard drive." We had someone else that was saying, "Oh yeah, I think I've got a photo of a map of something that someone once made," and it's chaotic because it's like all of these data sources are being stored in so many kind of random locations instead of one centralized repository. So us working together and us being able to have tools that actually do provide a platform that we can get all of that information into one space is such an important mechanism, and then to have the methodologies to disseminate and share that information. Thanks for bringing up data collection. Mohammed, just wanted to add to that one.
So Haley.
Maybe I can just give a quick example. So the population mobility mapping, the first stage of that is participatory mapping, and it really is like a focus group discussion. And I think when we talk about collaboration, and I talked a little bit about power dynamics, it brings together people who have different information about, in this case, mobility or migration. So you can do this at a national level where you're bringing together the Ministry of Fisheries, which people probably don't think that they would know much about migration, but when we think about, seaports and things like that, they have a lot of information about migration and mobility. We bring together the labor ministry, we bring together the immigration and customs officials as well. And so by bringing together all these little bits and having this focused discussion, you can really pull together a better picture around mobility from all of these different aspects. And so it really is a whole of government approach when we're talking about migration. There is no one ministry that owns migration. And then you can do the same thing at a country level, at a community level. One quick example is that we did this exercise at a community level. You brought together, women who were working in the markets. You brought together traders, travel depot, like people who organize buses and trips like that. And we actually were able to identify, and we've been talking about traditional healers and the importance of that in some of these responses. We were able to identify a traditional healer across, this was in DRC, across in Uganda, and a porous border crossing. So not an official point of entry, not with a proper procedures in place, but just a porous border like we have in many places. And we were able to identify that this was really an important and prioritized location where we needed to establish some form of screening, because we found out that people were going across the border to seek support from that traditional healer. And so I think, again, just going back to that multi-sectoral collaboration, we wouldn't have been able to understand or come about having that information if we hadn't pulled together such a broad range of stakeholders to hold a very, very cheap, a very easy focus group discussion, but that bears a lot of fruit when it comes to actual implementation and prioritization of where we target public health interventions during a response.
Thank you very much. So I want to bring in some audience questions now, and I'm going to stay with you, Haley. So there's a question that asks, do you know to what extent the government's Ebola response team used your map insights? Example, would the Ebola response lead hold the same views?
Yes, no, great question, because you're only getting a one-sided view at this from me. We have received really positive feedback from the governments and the communities that we've been working with as it relates to the mapping exercises that we do. In particular, for instance, when you think about the borders of a country like DRC or even Uganda, there are a lot of points of entry, a lot of different mobility corridors that you would love to establish some type of public health screening or contact tracing or RCCE or hand washing. And so our map has really helped those decision makers at a national level and at a district level make those decisions around where do we want to prioritize when we have limited funds. And we have heard, again, positive things. We've also been requested by governments to actually train. So this is not necessarily an IOM methodology, but something that we actually engage with the national stakeholders to train them on, to train the communities so that they can also do this themselves if and when the situation requires it. And I would say if we could be doing more preparedness mapping, we would be a lot faster on our feet in order to be able to say to governments, hey, we've got this situation. We would advise that you put public health interventions at this POE, at this border crossing with this place of congregation, this marketplace, for instance, that's open on Tuesdays and Thursdays. I think we could be a lot faster on our feet if we had some type of preparedness mapping, baseline maps for a lot of these areas where we know that we have constant outbreaks happening. Thanks.
Excellent, thank you. I want to go to Esther and ask this interesting question, which is about the key challenges in collecting and harmonizing contextual data across different regions. So we have low and middle income countries and high income countries, and of course there will be some disparities there. And how can the WHO address these challenges to ensure more timely and effective public health responses?
Thanks. Yeah, great question, that one. in terms of the key challenges across different areas, I think some of it is around both the access to the data and the accessibility of the data, and also thinking about things. I think we briefly touched on it in terms of the confidentiality of data and data sharing, and these sort of things vary depending on the context, the country, the part of the world you're in, and then we have to be a little bit concerned about coverage. So there are some particular areas where we won't be getting information because of some of those factors I just mentioned, and then there is a big bias there that we can't interpret the data to the same degree. So I think there are many other challenges in terms of the diversity of the data, accessing data portals. We touched upon maintaining the data repositories and collecting data. But I think in terms of harmonizing across different regions, we don't necessarily need to harmonize. We need to think about the diversity in terms of the particular event we're looking at or the particular geography we're in. But then if we do want to think about harmonizing, I think there's an area of work we can do around data standards and data portals that feeds into that. So I think there is probably a multifaceted answer that I don't necessarily have at the tip of my tongue. But I think there are a lot of challenges that we have, and this is a really growing area. But I think it is something that, as we said earlier, hopefully new technologies, AI, etc., can support us in combining some of these data. And I think it's an exciting area that will take off in the next few years. Over.
Thank you very much. Still staying with challenges, I want to go to Mohammed. So I know some traditional healers also from my own personal experience from my own country, Ghana. Some traditional healers in Africa play a significant role in the provision of healthcare, as you have also demonstrated. But there's also a large proportion who have divergent perspectives, right, on the causes and optimal treatments for certain diseases. How significant of a challenge are these to the establishment of such a system that you have running in Sierra Leone at the moment, and how can we overcome some of these challenges?
Yeah, thank you very much for that question. I think it depends on mainly, the approach we as health professionals and epidemiologists use. If we see the traditional healers as part of the problem, then that's how we approach them. We begin to blame them. We begin to ignore them, and then they go, they also, become isolated. But then if we see them as part of the solution, then of course, we find ways of getting to them and understanding their perspectives. But most times we are very quick to ignore them. We had a similar experience in Sierra Leone. When we wanted to bring them in, people were saying, oh, you are now going to legitimize their approaches. They are doing, a lot of wrong things. Yes. But then you cannot, understand them if you don't work with them. So I think the main thing, is very challenging, but for us to be able to show respect, and work with them and, let them understand, that we are not dictating terms to them. We are not blaming them. Understand their perspective. We have different views, but then, over time, we now begin to understand ourselves and they begin to understand us. And they begin to now see that, yes, what we are doing makes sense. But then if it is us and them, it's very difficult. So I think what we did in Sierra Leone was to go back, spend time, go through the leadership of the traditional healers. Map them out. Let them see that whatever we are doing is for the benefit of the community and the country. And it will take time, as I say. It's not, a one-off approach. But then when it is based on mutual respect and trust, eventually you'll get to that point. And I think, that is what we should be doing. It has come, a long way. It's a long journey. But then, I think in Sierra Leone, we've been able to build the building blocks that we can now, use to, nurture a stronger relationship between us. Over.
Excellent approach. Thank you very much. So I will go to Sophie also with this very last question. If you can give us your input on how you make sure that there is map literacy in specific regions before working there, and do you contribute to this literacy?
Yeah, that's a good question. And the short answer is it depends. It really depends on the type of the project, and the literacy isn't something we necessarily kind of take into account. What we're interested in is because at the end of the day, a map's a map. It's the person who is looking at the map and interpreting the information and contributing to the information that actually has the impact. So yes, map literacy is important in terms of getting kind of digitization and empowering local people and closing the digital divide, things like that. Yes, but do we train people in the actual functionality of a map? Only when it's appropriate. And when we want to work with the community to build out, say it's an education project or something. But yeah, very, very dependent on the context.
Excellent. Thank you very much to all my panelists for the very engaging discussion that we just had. I will hand over to Sarah to continue the rest of the program. Thank you very much.
You can stay. Yeah, I really want to also thank the panelists and our moderator for a really, really interesting discussion. I think one of the takeaways is, while we would love to have one single source of information to answer all of our questions, that unfortunately will never happen. And you really demonstrated that there's the diversity of sources that's incredibly important. There's also often the difficulty of identifying them and pulling them together. The analysis itself can also be rather complex, and really at the end of the day, we can't bring this contextual data together unless we are recognizing the importance of getting the data from the source, engaging the communities and local partners, the potential for building out open sources, as well as harnessing new technology and innovation. And I would love to close with the importance of collaboration, which we appreciate was highlighted here. That's really why the hub is here and why we were built, to help foster the convening and the collaboration and these types of discussions that are needed to help bring intelligence and surveillance forward. So I want to thank the audience. For those who are in the room, we invite you to join us for a reception right now. And those in the room and online, please look forward to the next speaker series coming up towards the end of the year. We will let everybody know about that. And then I also want to give a big shout out to Charité for co-hosting, and to the WHO staff that pulled this together. This is a really complex thing to do, and they are superb. So thanks to everybody. Round of applause for being here. Reception.